Good morning, everybody. Are you able to hear me?
Yes, sir, we can hear you.
The others have to get back to us. Ellen, that's okay. Let's speak it. Hello.
Hello. Can you hear me?
Yes, sir, you're audible, sir.
Okay. Very good morning to all of you. And to begin with, let me thank Dr. Sujata for inviting me to interact with you and participate in this discussion on role of kidneys and in critically ill children. So let us, so you are all okay, you are able to hear, right? Can you just respond if you are able
Yes,
to hear
sir,
me?
we can hear you, sir. We can hear you.
Okay, so let's begin.
என்னாச்சு எல்லாத்தையும் க்ளோஸ் பண்ணுங்க. See which one moves. இப்பதான் எல்லாம் டெஸ்ட் பண்ணிட்டு திருப்பி அதே ப்ராப்ளம் ஆச்சுன்னா wait. எங்க கை It's only 1 million. Oh.
So good morning again. Sorry for the delayed start, but let's get going. Yeah, so let us start with a very common scenario that intensivists would come across. And this is a 2-year-old child with sepsis and fluid refractory shock, ventilated and on 2 inotropes. So, this sort of children with multi-organ failure and, hemodynamically quite disturbed children, you see them very often. Now, this child had urine output 1.5 ml per kg per hour and creatinine of 0.4 milligrams per deciliter on
Sorry
admission.
to interrupt, sir, but the screen is not moving.
Screen is not moving. Now?
No, sir, we are only seeing the title slide, that's it.
அதனாலதான் half 15 minutes முன்னாடி வரணும்னு சொல்லுது. ஓகே
Yeah,
Now is
it's
it moving?
Yes, sir, it's moving now.
Okay. I think yeah. Yeah. Is it moving now?
Yes, sir.
Okay. So let's get going. So on admission, output was good. It was non-oliguric and creatinine was 0.4, which is normal. And this doesn't happen very often, as you know, because a lot of children come to ICU late, and you don't have a baseline which may be normal. The baseline to begin with may be abnormal. But anyway, we'll discuss that. The output on day 3 from 1.5 ml per kg per hour had dropped down to 1 ml per kg per hour, and the creatinine from 0.4 to 0.8. So, does this critically ill child have acute renal failure? The conceptual definition of acute renal failure, there have been multiple conceptual definitions. There are more than 30 definitions exist in literature. So basically, it is just a minute.
Not able to find the mouse.
Let me. This one should minimize, no?
Yeah. Okay, sir.
So abrupt loss of renal function measured by declining in GFR and loss of kidney's ability to regulate electrolyte acid-base status to attain hemostasis, all this ability are lost with the accumulation of metabolic waste products. And previously, this was known as acute renal failure. And there has been a change in terminology, as you know. Next. So there is a limitation.
Go back. You want forward or back?
Yeah. So as you know, there is a change in terminology. Nobody uses the term acute renal failure, and we'll discuss why this is so. Now there is a problem with labeling something as acute renal failure because it straight away divides the children into two compartments: normal children, normal kidneys, and children with abnormal kidneys. To the extent that they have failed. So, whereas we need something which will give a statistically, different grades of renal insufficiency, we may call it. So, we need something more precise, and which is not possible with acute renal failure terminology. So, we go for acute kidney injury. And now, acute renal failure. But still, there are some issues, like mostly this has been tested in ICU or tertiary hospital settings. And we really miss out on children with AKI who do not have complete data, which is the baseline creatinine. So we always need a clinical judgment while using these definitions. So the acute renal failure terminology was changed to acute kidney injury in 2004. And it reflects the entire spectrum of AKI, right from risk to the end stage kidney disease. I'll show you those pyramids. And it's not the term failure had a problem that it always meant failure of the kidneys, failure of its function. Whereas, as you know, if you take pre-renal type of renal failure in olden days, the kidney is essentially normal in those situations. If the child is volume depleted, and in short, the kidney to begin with, which is normal, will try to retain salted water, and child will become oliguric or oligoanuric or even anuric. So this
Excuse me,
kidney,
sir.
if you
think they are not seeing the slides moving.
again,
Change பண்ணுங்க. அந்த சைடு அங்கே இடம் இல்லை.
please wait. There seems to be some issue here.
I don't have any. Banu, are you seeing the slides moving?
No, ma'am. The title slide is there, ma'am, currently.
Okay, fine. Move on. Now,
Yeah, ma'am. Now able to see it's moving.
okay.
Okay.
We'll
Shall I
wait.
move on?
Yes.
Sorry. Yeah. Okay. So, we don't know why we started calling this pre-renal type of so-called renal failure as failure. It in fact should be termed as renal success, because the kidneys, which is essentially normal at this stage, is responding to volume depletion and altered hemodynamic status and trying to retain salt and water. So please remember that all this, the terminology of acute kidney injury is helpful to grade the various stages of AKI, and it will also address the issue of early detection and potential for responsiveness to early therapeutic and preventive interventions. So this is the conceptual model of AKI, which you are all familiar. And we used to pick up the acute renal failure in olden days when, after the GFR has fallen substantially, and that is reflected by, that is calculated from the serum creatinine and by modified Schwartz formulas, and that is already too late actually, because the damage has already started here. To begin with, it's a normal kidneys, then the kidney which is at risk, then kidney who begins to get damaged, and this is where we need to pick it up in an intervene. But that doesn't happen currently in most cases, because we pick them up only when the creatinine has shot up or output has dropped drastically. And then or we pick them up when they already need, renal replacement therapy. And we don't, of course, want any mortality for children with AKI. So, okay. So the various criteria have been developed. This is known as the rifle criteria. And there is a P rifle, which uses the percentage decrease in GFR based on Schwartz formula. So rifle stands for risk, injury, failure, loss of function, and end-stage kidney disease. And obviously, there will be many more children who are at risk, and we pick them up only when there is a failure in this third step, as you see, as we go down, risk, injury, failure. We need to pick them up early, the children who are at risk. Then there have been some other criteria, but just to introduce you, there is a Akin criteria, which which divides it into stage 1, 2, and 3. Essentially, they take into consideration the creatinine levels and also the urine output criteria. So these are Akin criteria. KDIGO criteria are basically developed by adult nephrologists and intensivists, but with some applications in children. So it does address for older children who are less than 18 years, but more than 12 years. So it is-
Yes.
So how common is acute kidney injury in hospitalized children? So this is one of the articles in Indian Pediatrics, Indian data. The incidence of AKI was almost 36% in the critically ill patients. By critically ill, I mean those who are on ventilator, inotropes, high dose, and and maybe with multi-organ failure. But even in non-critical, as many as 9-10% have developed acute kidney injury at some stage. And what is interesting is in almost all stages, the mortality in patients with and without ICAI was 37% and 8.7%. And it will depend on the stage 1, 2, 3, the mortality as the AKI becomes worse, the mortality goes on changing. So many years ago, I had written an article. This is almost 10 years ago, but even today it holds true that we are missing a lot of acute kidney injury. So we must keep looking for it and don't ignore it. We'll discuss this further. Because even small rise of incremental rise in creatinine cause increased morbidity and mortality. As you know, the creatinine builds up and becomes double only when the GFR has fallen by almost 50%. So it's important that, but unfortunately, there are no other better criteria that we have to pick up AKI in early stages. Well, there are some developments in terms of biomarkers and all that. So as we go along, we'll look at it. So how is the pattern different in developed country versus developing country? Yes, it is. In developed country, most of them are hospital-acquired infections. There may be a lot of non-infectious etiologies, for example, post-transplant, multi-organ transplants, and so on. Whereas a developing country, we still, I think here we need to make a distinction. The place where you are working now is not truly representative of the entire country and the entire range of our country population. So that's why here you may not see a lot of community acquired, and what is applicable to developing country, you may see more of what is written under the column of developed country. But nevertheless, community acquired infections, predominantly infections, and also you are aware that in developing country we have issues of poorer outcomes, delayed detection and accessibility of RRT being poor are the main reasons. So there is a difference of the pattern of AKI. In developed country, you will see more of, for example, bone marrow transplants, malignancies, accidents, and these kind of pattern, and not so much of community acquired infections. So a study was performed, the observational study, acute kidney injury in children, admitted to PICU. And the conclusions of the study was the AKI was common in children admitted to PICU, as much as 1/3 cases. Majority of children have AKI at the time of admission itself. Children who are more ill or requiring invasive ventilation and or inotropic support are more likely to have AKI. More than 1/3 of children do not completely recover their renal function. This is interesting. We always used to believe that AKI is something completely reversible, and at the end of your treatment, the child will have normal kidneys. But it may not happen. There may be some residual renal deficit in the form of hypertension, proteinuria, or decrease in GFR. And these may be long-term effects which you need to worry. So AKI is not completely and totally reversible in all cases. And our aim of treatment should not only be deal with handling the immediate issues and acute problems and risk to life, but also in terms of how to preserve the renal function so that they don't develop renal sequelae. AKI is independently associated with length of stay, but not mortality. If the AKI is picked up on time and treated appropriately, then it may not affect the mortality. You may be able to salvage, but length of stay will definitely be prolonged the more severe the AKI. And lack of baseline creatinine in AKI at admission may limit the use of AKIN criteria to classify in developing country and needs to be modified. I think since we are started late, I may have to. So this is the syndrome of AKI, as I said, starting from pre-renal, renal, and post-renal. And the important pre-renal would be severe diarrhea, vomiting, burns, hemorrhage, sepsis. And in addition to that, what we often forget or not take into consideration is decrease in effective intravascular volume. So anaphylactic shock, septic shock, dengue hemorrhagic fever, or there may be capillary leak. Also patients with cardiac failure, increase intra-abdominal pressure and so on. Renal, as you know, could be broadly divided into glomerular or tubulointerstitial and vascular lesions. And post-renal is something which requires surgical intervention to bypass the obstruction if the urinary flow is obstructed. And there are a lot of risk factors for AKI which need to be kept in mind. And we need to measure the creatinine at least daily and monitor urine output thoroughly. So what is important is what is the perfusion of kidneys and how much is the GFR, how is it responding to the changes in the body status. So susceptible are, if you are a neonate, you are at more risk compared to an older child. If you already have a chronic disease, chronic kidney disease, chronic other diseases, malignancies, diabetes, anemia, all these are risk factors. And of course, the other exposed factors are sepsis, circulatory shock, burns, trauma, major surgeries, nephrotoxic drugs, radiocontrast-induced drugs, and poisonings. So it is important to give attention to preventing AKI, or if not completely prevent, reducing the severity of AKI. And then the most important being maintenance of fluid balance and preventing hypotension. Then there are some examples I have given, like contrast nephropathy. You know that the children should be properly hydrated, and or we should make sure that low or isoosmolar contrast agents are used, and there is a role for use of oral N-acetylcysteine. In tumor lysis syndrome, there is a role for hydration and alkalization of urine. and use of drugs such as allopurinol or aspirin. In patients with crush injury, there is a role for with a tubular block, for example, myoglobinuria, there is a role for hydration and alkalinization of urine. Nephrotoxic drugs, uh, it's quite common exposure, and sometimes we have no choice but to use nephrotoxic drugs. But as far as possible, avoid nephrotoxic drugs. Adjust the dosage based on GFR. Administer aminoglycosides as a single daily dose. Suggest using liposomal amphotericin rather than conventional amphotericin. So these are some of the examples how intensivists can play a role in preventing AKI. Yeah, so the history and physical examination is important, and they may give some clues to in the underlying etiology. And we should look for complications of AKI such as fluid overload, hypertension, and uremic symptoms. Uncover underlying risk factors. We already saw what are the different risk factors, and history of medications for nephrotoxic exposure. And evaluation of volume filters is very critical, both for hypovolemia as well as for fluid overload. Now, often we have been taught about maintaining fluid balance, mainly focusing on dehydrated state. But what is forgotten is a cumulative fluid overload is as bad as the dehydrated state, and it is, we can say that it's a forgotten vital sign. And we always have a look at percentage of fluid overload, and as it rises, we need to intervene. Now, for example, I always quote this that when I go on rounds and ask what is the urine output to the residents or nurses for a critically ill child, what's the urine output? No, urine output is fine. It's 1 ml per kg per hour. It's more than that. So they are very happy. And then I go further deeper and I say, okay, it is 1 ml per kg per hour. So if you have a 10 kg child, you have per day maybe about 250 ml of urine output uh, per 24 hours. But how much, can you tell me how much fluids you have given this to this child? And it may happen that this child had received 4 liters of fluid previous 24 hours and had put out 1 ml per kg per hour. So there is a huge cumulative fluid overload which needs to be handled. So this is a very commonly done mistake that look at urine output as an isolation. Please look at it in relation to the fluid intake and other losses of fluids if there are, and then only interpret the urine output. So I think urine analysis plays a role in differentiating between glomerular and tubular renal disorders, and presence of cast, as you know, in acute post-streptococcal nephritis is the most common example quoted for glomerular diseases, whereas the ATN and acute interstitial nephritis, mostly drug-related or some of the infections also cause acute interstitial nephritis. Those are tubulointerstitial. So as you know, when broadly speaking, glomerular diseases, oliguria, hypertension, hyperkalemia, fluid overload. These are the major issues in glomerular diseases. In tubulointerstitial diseases, they may be non-oliguric. They may have, essentially normal urine analysis. They may not be hypertensive. So these are and they, management wise, they are easier to manage because they don't have an issue of hyperkalemia since they are non-oliguric. So one must try to always, whenever there is renal involvement, to differentiate between glomerular and tubular interstitial diseases. There is a role for determining or differentiating between pre-renal and intrinsic renal. And the commonly used test is a fractional excretion of sodium, and there are some others such as specific gravity, osmolarity, and all. So sometimes they are useful, but please remember, if the child has received diuretics, and then all these indices have no meaning, because the diuretics per se will alter the urinary salt values. So you have to interpret this in the context of right clinical setting. And I think I won't be exaggerating if I say that instead of using urine chemistries, use the fluid overload, fluid load and response to the fluid load, or giving a fluid challenge is much more helpful to differentiate between pre-renal and intrinsic renal. Some of the clues from the lab: hemolytic uremic syndrome, if there's anemia, which is microangiopathic hemolytic, where the peripheral smear is diagnostic, and there are other evidences for hemolysis. Sepsis associated AKI, there may be anemia, leukocytosis, thrombocytopenia, features of DIC, and cultures you will have to keep looking for. Rhabdomyolysis, there is a hyperphosphatemia, hyperkalemia, and raised creatinine kinase and myoglobinuria. And hyperkalemia and raised creatinine is out of proportion to the rise of creatinine. And it's a hypercatabolic state. Tumor lysis syndrome is another hypercatabolic state where you have hyperuricemia, hyperphosphatemia, hypocalcemia, and uric acid crystals in urine. And there are some other examples. Ultrasound is useful to pick up obstructive uropathy, and then the management is totally different. Unless you clear the obstruction or bypass the obstruction, you won't be able to bring out the child. So to rule out obstruction, but also, the renal size per se, if you come across a chronic, small contracted kidneys, then you may have to think that is it AKI or is it acute on chronic kidney injury. So in that way, the kidney size is crucial. We expect kidney size to be normal in acute kidney injury, but if you find it to be small and shunker, it is suggestive of an underlying chronic process. Enlarged kidneys, like in pyelonephritis, renovascular hypertension, acute interstitial nephritis. But markedly enlarged would be obstructed kidneys and polycystic kidney disease. And you look at the echogenicity as well, it will be increased in intrinsic renal disease. Routine management, as you know, monitoring creatinine urine output, role of fluid challenge, and then look at simple urine analysis, other tests like electrolytes and calcium phosphate balance in order to pick up underlying chronic disease if there is. And then renal ultrasound. This is a standard, immediate approach. And you start treating the underlying cause. And if the things are not doing well, then the treating doctor is required to transfer them to higher centers and seek the opinion of intensivists and nephrologists. And usually, as you know, these things happen over the weekend and during the nights. So the treatment principles remain as we said, depending on the stage of AKI. So treating underlying cause, ensure volume status and perfusion pressure. Avoid using excessive vasoconstrictors, because those will reduce renal perfusion. Discontinue all nephrotoxic agents when possible or alter their dosage. Consider functional hemodynamic monitoring, so arterial lines and all that, and then monitor creatinines and output, avoid hyperglycemia, consider alternative to radiocontrast, and at appropriate time, you will have to think of giving renal replacement therapy. So consider dialysis, we'll talk about. And of course, managing acidosis, hyperkalemia, hypertension, this is during all the stages. So fluid management, maintain blood volume, avoid overload, management of electrolyte abnormalities, acid-base management, stop or modify dosage of nephrotoxic medications, management of hyper. These, see, even if a child requires a dialysis or renal replacement therapy, all these other things are very important at every stage. Fluid therapy in AKI, as you know, to begin with, if the child is dehydrated, has a low circulating blood, you need to give more fluids. But once you have attained a good fluid, balance status, then if the output is guided by urine output, and you have to restrict fluids for 100 ml per meter square, which is the insensible loss plus urine output will determine. So you have to really consider fluid as a drug which needs to be dosed. And fluid resuscitation should be protocolized. If we have to establish the goals, why we want to do it. And you must know when to pick up a volume, when to differentiate between volume responsive AKI and AKI which will not be volume responsive, and in fact the general condition may get worse if you keep giving more volume in a child with oligoanuric. And isotonic crystallized preferred for resuscitation, except in patients such as, for example, who have low albumin, serum albumin to begin with, you may want to use colloids at an early stage. For example, children with nephrotic syndrome in shock. But generally speaking, we tend to use crystalloids, except in this low albumin status. Avoid potassium fluids because till you get electrolyte reports, because it's easy to correct hypokalemia than hyperkalemia who is already in renal failure. I think we have talked about this. Now, if you notice a child who has oliguria, it's an oliguric type of renal injury. And what is the role of diuretics, high dose diuretics like furosemide? We generally say that the use of diuretics will convert oliguric renal injury it may convert oliguric to a non-oliguric renal injury, but overall it may not alter its prognosis. But it will become easier to manage this child if you turn the child from oliguric to non-oliguric. But it's not known to prevent AKI. Now, special consideration should be given to urgent relief of urinary obstruction, if any, adequate fluid resuscitation to restore an effective circulating blood volume, prompt restoration of effective BP, avoidance of fluid overload, and stopping potentially nephrotoxic drugs. I keep on harping on these points because those are very, very important. Indications for dialysis, as you know, it's not only for reducing urea and creatinine levels or so-called uremic toxins, but for so many other indications such as acidosis. If you have a child with severe metabolic acidosis, which may have a deleterious effect on the cardiac function, especially in presence of hypernatremia, you can't go on using bicarb, and you will resort to treatment with dialysis merely for acidosis, when child may not have severe accumulation of waste at this point, but just for acidosis you will do. Similarly, you may have to do it purely to remove fluid in a child with fluid overload, although renal function as such in terms of urea and creatinine may not be that bad. So all of you are familiar with this. Hyperkalemia is of course very important for indication for urgent or emergency dialysis. You are aware of these various modalities of treatment and pros and cons of PD, HD, and CRRT. I have some examples later on to give you, which one is to be used when. But let us take one by one. Solid removal, which is very good with hemodialysis, quite good with CRRT, but not so good with peritoneal dialysis. Fluid removal is excellent with hemodialysis. So hemodialysis is very good for rapid solid removal, and it's very good for rapid fluid removal because you can do ultrafiltration, right? Yeah. So need for hemodynamic stability is an issue for hemodialysis. And efficiency for treatment of hyperkalemia is again excellent. So to tide over the crisis, if a child is hemodynamically stable, hemodialysis is fairly good and should be sought after. But PD is not bad because hemodialysis, you may require a lot of equipment and expertise, and it cannot be provided at the peripheral centers. So there PD does play a role. Ease of access is a problem with hemodialysis as well as CRRT. You need good access. Hemodialysis is not a continuous process, whereas PD is more physiological. CRRT is also a continuous process. Hemodialysis requires anticoagulation, and there is a possible respiratory compromise with PD because you are putting in a lot of fluid into the abdomen. And also there is risk of peritonitis with PD. Disequilibrium. Now, if the urea and creatinine levels are sky high, let's say a 2-year-old with a urea of 300 and creatinine of say 5, 6, it's very high for him. And if you suddenly rapidly reduce these levels with hemodialysis, there is a risk of disequilibrium because you will be reducing the urea from say 300 to 100. So there is a tremendous drop in the osmolarity, and there is a difference in the osmolarity in the CSF, in the CNS versus outside CNS, and because of sudden drop in osmolarity, the fluid rushes into the intracranial department and cause severe disequilibrium. Child may have headache, vomiting, altered sensorium, even seizures. So you don't want to rapidly reduce very high levels of urea in fear of disequilibrium. And of course, trained staff is more available, required in HD and CRRT compared to peritoneal dialysis. Yeah. Now, which modality to choose? 4 questions to be asked. Do you want solute removal? And that means, do you want urea to be reduced? Creatinine is not so the clearance for creatinine is not as great as for urea. So, how much urea reduction you want, or are you doing it for electrolyte imbalance? What is the indication for renal replacement therapy? So, is it purely volume fluid overload? And how rapidly you want to reduce it? Is the patient hemodynamically stable? And what resources you have available? And you have to use the modality that is available, first of all, and then affordable and which can be provided safely. So in resource limited settings, PD is the choice. Whereas in advanced centers, referral centers, you have to think in terms of HD or CRR as well. These are clear indications for AKI referral to a nephrology team. Hyperkalemia, pulmonary edema, refractory metabolic acidemia, and rapid rise of urea and creatinine, so worsening azotemia. As I told you, there may be a role for biomarkers, but this is even today at experimental level in order to pick up the AKI at an early stage, even before the creatinine has gone up. And if you pick it up, then to intervene early and take all the necessary steps to prevent further deterioration or progression of renal disease. One of the examples of biomarker is the NGAL, but we'll not go into those details because it's not really of practical implications at present. It's a more of research tool or so we'll not talk more about it. The acute kidney injury management is so important because and that's why as you know, World Kidney Day has been celebrated every year and by International Society of Nephrology, and for every year they give some theme. And for 1 year, the theme was Kidneys for Life, Stop Acute Kidney Injury. Now let's talk. I think I have another 5-10 minutes.
No, sir. You can complete.
Okay. So whenever we come across AKI, we always say, how am I going to increase the outcome? And as I said, it doesn't only mean treating the life-threatening complications of AKI, but also it includes handling AKI very meticulously so that you don't end up with a residual loss of renal functions and development of chronic kidney disease. So it's a teamwork. Managing AKI is a teamwork. Intensivist actually plays a bigger role than a nephrologist because he's the one who is at the forefront and is going to try to prevent the AKI. Of course, even despite all efforts, AKI may still develop, and then together, nephrologists and intensivists can manage it. So that they will decide the indication for dialysis or renal support. And early detection is timely intervention is because that is what makes a difference. That will have an effect on the length of stay, of overall outcome, and so on. So acute kidney injury is by and large reversible. Although, as we said earlier, that about 15-20% may develop some chronic disease. But our dream when we manage such patients with acute kidney injury is at the end of it, we want a normal child with normal kidneys. That is our aim. So in presence of reversible factors, the best time to treat renal failure is before it occurs. So looking at reversible factors and managing, taking preventive steps is so important. Why do we worry about AKI and critically ill? Because it occurs, it's quite common. That's one. And kidney is not just a spectator and a sufferer in a critically ill child, but it is nowadays, we talk the concept of organ crosstalk. That means kidney injury is seen as an engine rather than a sign of multiple organ dysfunction. So if you have other organs, so it becomes an integral part of multi-organ failure. And if the kidney is not working in, even the other organs, it will have a base effect and vice versa. So this is the concept of organ crosstalk. I think we talked about this, that fluid therapy is very important, and consider it's very important. You don't want to underhydrate, or you don't want to overhydrate. Fluid overload, don't ignore it. Cumulative fluid overload. And as I mentioned, avoid a common flawed practice of interpreting absolute urine output. Always relate it to the fluid intake. Now, the published consensus and the practice in most centers is still to offer dialysis to relatively ill patients rather than to relatively healthy patients. But I would like you to look at it in a different way and don't consider dialysis as mere, effort to be made only at the end. And we should be very aggressive and dynamic in terms of initiation of early dialysis. And we expand the scope of the indications for dialysis, not just for uremic toxin removal, but also to treat fluid overload, to treat other complications, to preserve renal functions, to preserve other organs. So I would, if I were to give one message today, I have to say that don't look at nephrologists and kidneys only for dialysis or renal replacement therapy. Look at them and consider dialysis as a renal support rather than just on what are the lab values and all that. You have to see the overall progress that the child has made or has not made, and then make decisions about dialysis. Consider it not as just mere renal replacement therapy, but as renal support. And these are various indications like the modality could be intermittent or continuous. Intermittent, uh, intermittent hemodialysis, extended daily dialysis, and slow low efficiency dialysis or SLAD. These are intermittent therapies. Continuous therapies would be PD or CRRT, and CRRT could be, as you know, continuous hemofiltration dialysis, and also hemodiafiltration and continuous ultrafiltration. So these are all different modalities of renal replacement therapy. And complications, I mean, AKI is such a vague, such a broad topic that one can go on talking on various, each aspect of it and the whole thing can go on for 2 days. But I'm trying to give you some points here and there which try to change your approach to patients with renal disease and develop an important team member of managing a child with renal disease. So, peritoneal dialysis, complications, specific peritonitis. If you remove too much of fluid on PD by using hyperosmolar solutions when they are not required, if they are not required, then you will develop hypernatremia. You may develop hypokalemia, so you have to manage electrolytes and add potassium to the PD fluid if required. Hyperglycemia, sometimes requiring insulin intraperitoneal administration, and then some other rare hydrothorax or organ injuries. Hemodialysis, hemodynamic status is an important issue. Disequilibrium syndrome, if you rapidly remove the urea. So the way to go about is give a slow dialysis, reduce blood flows, smaller dialysis doing the first thing. Don't have a countercurrent flow of dialysate and blood. So that is the way to earn use of mannitol in some situations or you give a PD prior to switching them over to hemo. This is all to prevent disequilibrium syndrome if you have very high levels of urea. So you don't want to drastically drop them. Hemodialysis is quite efficient that way, but sometimes too efficient. And CRRT, you have hypophosphatemia and hypomagnesemia are commonly encountered, which are not seen so much with hemodialysis or peritoneal dialysis. And hypothermia, because it's a continuous process. Yeah. So I think I will just go over some of this scenario. A 6-month-old child with history of diarrhea, presents with AKI, that is BUN is 165, creatinine is 2.6. As you can notice, the BUN is disproportionately high. So when that happens, you have to suspect there may be underlying pre-renal state, or there may be pre-renal superimposed on intrinsic renal because of disproportionately high level of urea compared to creatinine. So this child has presented with this AKI, and it is worsening. Child is remaining oliguric, not responding to fluids. So you are beginning to get into fluid overload, which you don't want. So you need to restrict fluids. So what will you use? I think I have given the answer there. Acute PD works very well in such situations for various reasons that you, yeah. The PD is very easy to institute. You don't require too high technology. It's not that expensive. It can be done in peripheries. And it is life-saving. And you can give a seating for about 48 to 72 hours, then discontinue. And if there is this diarrhea has led to ATN, you can restart it and give another sitting. But if somebody is going to require more than 2 sittings of PD, acute PD, then I would think we should think about using hemodialysis. But this is a small child, so age may also have a determining role. Let's go to the second example. 8-year-old diagnosed as post-streptococcal glomerulonephritis presents with severe breathlessness, potassium of 7.5, creatinine of 3. So clearly these are life-threatening complications. His breathlessness is probably due to pulmonary edema and could be contributed also by hypertensive congestive cardiac failure. So there is fluid overload, pulmonary edema, breathlessness, hyperkalemia with imminent risk of producing cardiac arrhythmias and life-threatening. The creatinine is such an issue, but the other two necessitate immediate management. Of course, you will take all your measures to combat hyperkalemia, like stopping potassium, IV calcium gluconate, IV soda bicarb, potassium binding resins. So I think you are all aware of those, and also nebulizations. These are all temporary measures. They don't really get rid of potassium out of the body. So you need dialytic support. Then hemodialysis is if the child is hemodynamically stable. Otherwise, you can initiate that and you will get a rapid reduction of potassium. You will correct acidosis quickly, and you will ultrafiltrate and remove fluid as well. So you will get rid of pulmonary edema issues. So hemodialysis, acute hemodialysis. But if it is not readily available and it's going to take time, even PD will work better. And in such cases, if you are doing it more for fluid removal, you need to use hyperosmolar solution of peritoneal dialysate. And in PD, you give smaller cycles, smaller indwells. If you are metabolic acidosis and hyperkalemia are major issues. If you are doing it for those indications, use smaller indwelling. Instead of using usual 30 minutes of indwell, you use it short cycles, 10, 15 minutes of it. A 6-year-old, let's go to the third example. The 6-year-old child is diagnosed with D- HUS with AKI and is anuric. So it's not a post-diarrheal HUS, it's a D- HUS, which is likely to lead to persistent renal failure for quite some time. So sitting of acute PD may not be of that helpful, but continuous PD may have a role. And either continuous PD or hemodialysis. Initially, for hemodialysis, you may need to create a temporary access, such as interjugular or subclavians. double lumen catheter insertions. But if the PDHD is going to be a prolonged one, then you may need to create a permanent access or put a perm cath or go for a AV fistula, so on. So in this situation, I would consider hemodialysis as continuous PD. A 14-year-old child is diagnosed with dengue shock syndrome and AKI. He has hypotension and is oliguric. He has mild hypotension, so it's borderline. It requires the intensive management of hemodynamic status, but it's not that it is manageably maintained. So in compared to the next patient, which we'll come to later, but in such situation when the hemodynamic status is not all that too bad, but patient requires dialysis support, SLED is a good choice. Because as you know, CRRT is labor intensive and may not be easily possible, but SLED you can be done with a regular hemodialysis machine, and you can use PD as well if SLED or hemodialysis are not possible. But this requires real tertiary care setup, and the last example of D minus HOS with AKI, I mentioned about continuous PD, and there are a lot of studies now saying that if you do a tidal PD, that means you leave a residual amount of some fluid in the peritoneum, and on top of that you put in some more fluid and carry out the cycle. So there is a residual volume, sitting volume in the peritoneal cavity. That's called a tidal TD. So there have been some good reports of using tidal PD as good as with hemodialysis. Yeah. Now, the 3-year-old presents with severe pneumonia, and it develops then multi-organ failure. It is hypothermic shock, requiring 3 inotropes, severely overloaded, have a tremendous cumulative positive balance, and is anuric. So this is an excellent indication for CRRT. And if it is not possible, then PD can be considered. Hemodialysis, if you won't be able to think about it, because hemodynamically, this child is not stable. He is already hypotensive despite 3 inotropes. So hemodialysis is not a choice. And so SLED also is not a choice. So it has to be CRRT or surprisingly PD. Even in patients with hypotension or lower blood pressures, there is some good clearance from PD, which we normally tended to think that PD is not very effective, but it's not so. It can be considered as a continuous dialytic therapy. But CRRT is ideal. This is a perfect, CRRT is very ideal for, remember 2 things. One is if the patient is tremendous fluid overload and you want to remove that fluid in a calculated way. And second is if the child is terribly hemodynamically unstable. These are the 2 major indications for CRRT. So CRRT or PD. Also remember, we said that we have to keep in mind what is feasible and what is available, what is affordable, and it can be provided very safely. The same modality treatment you have to go for, but don't underestimate the role played by PD. But you should always be ready to go ahead with HD or CRRT in patients who are really critically ill and with multi-organ failure, and who are hemodynamically stated and volume fluid overloaded. I think we probably need another session to discuss individually about some issues related to PD, issues related to hemodialysis, various types of hemodialysis, and various types of CRRT, etc. Always remember that even if you choose one modality, you may want to reconsider or shift patient from say PD to HD or from HD to CRT. It's not that once you have started one modality, you have to keep on doing that. You have to reassess these patients as we go along. So this is the clinical actual pyramid. You look at the base. This is the very important one. Identify those which are vulnerable to develop AKI. Early detection, strict monitoring of for electrolytes and other parameters to assess the ongoing renal function. Then review for most common reversible factors. So volume status is critical. You don't want child is underhydrated or overhydrated. So in addition to central venous pressure monitoring, IBC index and so on, collapsibility index, and various other methods to assess the volume status. Because you want to be very energetic in handling not only the so you don't want to prolong or introduce renal failure when there was none by undertreating, and the rapid correction of underhydrated state is important. But so also the importance is to handle the fluid overload and prevent cumulative overload, because that definitely prolongs the morbidity of acute kidney injury. Supportive therapy is the cornerstone. Think twice before initiating therapy that may cause AKI, and then dialysis if conservative measures fail. So good judgment comes with experience, and experience comes with bad judgment. So remember that. Okay, so I think, sorry we had to start late, we couldn't start earlier, but this was just an introductory session, if you can say, for touching upon few points of AKI here and there. So mainly I concentrated on the spectrum of AKI and the role played by intensivists in assessing various things, and working as a role model, working as a team to improve the outcomes of AKI. Thank you. So, Dr. Sujata.
Yeah. Thank you so much, sir. So any questions from the team? Some things that I learned quite a lot. One was, sir, you told us about, don't wait for the creatinine to rise. Look at the creatinine trends.
Yeah.
Because that's where you pick up the problems. And also you spoke a lot about the cumulative fluid overload.
Yeah.
So for us intensivists, the real challenge is the first 24, 48 hours before the child gets into those stages. As you said, if we have a baseline creatinine, it helps us to find out whether the trend was up or down.
Right.
So I'm just trying to understand, what are the key tips for us so that we identify them early in terms of the rising creatinine trends. What can we do? What is the expected rise of creatinine that we can accept safely? And what are the ones that, what's the rate of rise that we should be alarmed about?
I would give a lot of importance to response to your fluid therapy.
Okay.
Now, for example, if you say, if you are looking at managing a child who is dehydrated following gastroenteritis, and you start giving fluids, you calculate your fluids as per, give a bolus or whatever, and the child is still dehydrated. So you have calculated it according to the level of dehydration, and you have given that much fluid, but despite giving that fluid, so there are few mistakes made at this point by in even well-developed ICU units, that if there is no response, the child remains oligoanuric after fluid therapy, then the immediate reaction is to give fluids. That is given, but even then the child is persistent dehydration, so they give diuretics. So no urine output, give diuretic. There is no role for diuretic unless you correct underlying dehydration. So that is the first. Second is even that happens when the BP is low, not coming up, start dopamine. Uh, yes, the child may need this inotrope, but the underlying fluid status has to be achieved before resorting to either diuretics or inotrope. So that's something which.
So what we tend to do in our unit is basically, I mean, my colleagues can just add on, is that the assessment happens with looking at the cardiac status. So they put an ultrasound probe, they look at the IVC, they look at the heart function, and then they kind of titrate their fluids or their, inotropes based on the cardiac assessment that goes on. Now, what my thing is, should we be looking at the kidneys also? So, should we be looking at the flow to the kidneys? Are there any other measures that we can do to optimize the way we give our fluids? Sometimes.
Yeah.
Probably not for us, pediatric.
Yeah.
So, in terms of this one, in terms of like the renal perfusion, should we be looking at those? How do we make sure we end up giving lots of fluids to children in terms of the first 24, 48 hours where we don't have a choice. We see our IVC, it is looking really flat. They're really volume depleted. So we are needing to give more blood products or fluids, whichever. And especially for patients like dengue, we give early colloids so that we don't have to, give too much of fluids and flood them. So this is where we look at first 24 hours, the cumulative fluid balance invariably is positive and like very positive. The next day, if we see a rising creatinine, what is the rate of rise that we should be alarmed about?
Yeah, I think if you're looking at a child where the primary problem is volume depletion and not so much like sepsis and just pure volume depletion due to fluid losses, which happens typically in acute diarrhea or gastroenteritis. And you calculate your fluids, and then you give that much fluids over a given period of time, and you find that the child is not improving. So now, if it was pure volume depletion, it should have corrected all this. That means we are dealing. So where is all that fluid going? Why? So there is a capillary leak.
Yeah.
So that is how we proceed with dengue and other sepsis. That it's not just. So that's what is the effective circulating volume. And you have no choice. I mean, if you have to normalize circulation, even though you may end up with positive fluid overload, because that will maintain the renal perfusion. So don't worry, even if you have to give 3 liters to produce 500 ml of urine, or 5 liters and produce 100 ml of urine, if you have to do it, you have to do it. But in such cases, go for early CRRT.
Okay.
Or go for, or the other example is the child is requiring a lot of, blood products. In which case, if you have to give, you have to give, but you be prepared to handle and sort of expectantly look at initiating child on early CRRT. And the dictum which I always tell is that if you have a child where you are you are doubting whether the child requires dialysis or not, probably he requires it. Yeah, it is just like, child with pyogenic meningitis suspected, and you are doubting whether to do LP or not to do LP or spinal tap. If you have a doubt, you better do it. So here is a role for early dialysis, early. So it is not only that you wait for the fluid overload to occur and start dialysis, expectantly, like, right now, you in next 24 hours, you need to give about 3 liters, and his current output is say 200 ml. Then you should seriously think of, even though the renal functions may be normal, there may be no other indications, purely to maintain an ideal fluid status, you do that. So you can't, I mean, if there is a leak, there is a leak, and you possibly cannot prevent a positive fluid overload, but you can manage it prophylactically, sort of.
So this rate of rise of creatinine is not a thing, or should we be studying it more?
Yeah, I think generally we expect that the creatinine per se will rise by about 1 milligram percent in a day. It is a very rough, because it depends on so many factors. And the other thing is, whenever you have disproportionate rise of urea, that means either there is a significant pre-renal issue, or there is a hypercatabolic state, or patient is on steroids. I mean, these are the situations where you have disproportionately high urea, and more than 0.5 to 1 milligram. So in a small baby, maybe about 0.5, but later on maybe more than 1 milligram percent. So you think of hypercatabolic state, the commonest being sepsis, and then patient on steroids, patient crushing injuries, status epilepticus, and these are all hypercatabolic states, burns. So in those situations, you will get or rhabdomyolysis, where you get rapid rise, and some of them may require, instead of normally hemodialysis, which is given alternate day, they may require daily dialysis, especially if they are hypercatabolic. So just as you are removing urea and creatinine, they are accumulating it much faster. So you need to increase the frequency of dialysis support.
Any other questions from anybody else? If you want, you can switch your videos on so sir can see who all is the team.
Sir, is hypernatremia detrimental to the AKI, sir? Because we will be more concentrating on hyperkalemia.
Hyperkalemia.
Hypernatremia. How vulnerable are kidneys for it?
Yeah. So see, hyperkalemia is a major is response to your urine output. If a child is oliguric, he is likely to develop hyperkalemia. If he is not oliguric, that's why the glomerular diseases and tubular interstitial diseases, this is a major difference. But if you hypernatremia, what happens if a patient begins to develop hypernatremia, there is a thirst mechanism, which is normally may not be in very sick, critically ill child, that relevant, but other patients, they just simply drink more water and normalize their sodium. In potassium, if the potassium level rises, it has to come out of the body, either in the form of diarrhea or in the form of urine output. If not, then hyperkalemia becomes an issue. That's why treating hyperkalemia is more difficult than treating hypokalemia. Hypernatremia would happen if the thirst mechanism is not effective. That means either in small babies or elderly people, or a child who has no access to free water. Hypernatremia is more often due to loss of free water, but rarely in ICU settings, it may be if you are given too much of bicarb or sodium load. So two important causes of hypernatremia. One is giving exogenous sodium bicarb and extreme sodium, or loss of free water and inability to normalize sodium levels utilizing thirst mechanism. That is essentially how hypernatremia develops. Hyperkalemia, on the other hand, is that it is not being washed out by kidneys. So that is the cause of hyperkalemia, where if it cannot come out of the body, because all these other measures of managing hyperkalemia, soda bicarb, inhalations, and calcium and all that, they are only temporarily shift the potassium in and out of cell, but they won't get rid of the potassium. So, and if the kidney is not functioning, what else? You have to resort to dialysis. That's why we tend to concentrate more on dialysis in hyperkalemia than hypo. But hypernatremia is also equally dangerous. And for example, if a child you have started on PD and he is becoming hypernatremic, it's because of loss of free water. You are removing too much fluid. So, or if a child is becoming brain dead, then obviously he is developing diabetes insipidus and he will develop hypernatremia. So you need to give more fluids. In case of suspect, working up for organ donor, use vasopressin. So it depends on the underlying. You have to hit at the etiology when dealing with these electrolyte issues. What is causing it? And unless you correct that, you're not going to reach anywhere.
Any other questions? I think CMI team also had joined.
Sir,
Yeah.
so how often you come across disequilibrium syndrome, sir, in the during the
Disequilibrium.
Dialysis.
dialysis? Because
Yeah.
because in the ICU we'll have, otherwise also the children will be on, especially when we are seeing a very sick child who are needing the CRRT going on. So how often, like when do you exactly suspect it is a disequilibrium syndrome, and how often you see, sir?
I think it depends on at what stage child comes to you. If he's coming from very far off peripheries, reporting to you late, and or somebody has misdiagnosis, and he has come to you very late, he will come with sky high urea and creatinine. We used to see this when I remember I started my practice some 40 years ago, and that time we used to see a lot of these things. When severe azotemia and the values of urea and creatinine which you cannot anticipate. The urea of 500, 600 creatinine, and complications which we don't see now is these pericardial effusions and severe euthymia causing CNS involvement. So those things, it invariably talks about a late detection. Otherwise, if you have received the child or you are onto the case from the beginning, it is very unusual for you to encounter disequilibrium. So it's only for far off places which are receiving patients late that you see. Otherwise, you will, under your care, you will not allow the levels to shoot up to that level. Yeah.
Thank you, sir. So I believe there are no other questions. So those are all our team members. So you saw Dr. Sangeeta and Dr. Sidhu.
Yeah.
Then there's Dr. Sinchana, Dr. Banu, Dr. Nandita. Kumar is our PICU nurse specialist. So they're all sitting, but there are quite a few people with them, I guess.
Okay.
So,
Nice meeting you all.
You can just switch on your videos if you're safe.
Yeah,
It's
in our
okay.
match.
They're not safe.
Okay.
Okay.
Thank you, sir. Thank you for
So you consider this as a sort of introductory talk, because I really didn't know what
Sure.
exactly
Okay, sir.
stress more on different issues of AKI as a whole
No, sir. I
or
think,
dialysis. This was an overall,
uh-huh.
so you might have.
I think
found
we
it-
wanted more like the physiology part of it to like say when to anticipate, what are the things, what could be the worst effects. So you have dealt with most of them. So thanks a lot.
And we can have some more sessions,
Sure.
on some very specific.
Specific topics, yes. We'll do it that way. Thanks, everyone.
Thank you all.